When it comes to lesser saphenous harvesting, we're going to use the same patient positioning as we did for the greater saphenous. Now, some centers would take this prone. They would have the patient literally on their stomach, and they would take the saphenous and then flip the patient over to do the procedure. This just isn't efficient, and I don't really know any surgeons that would be patient enough to allow this to happen. So what we've figured out is a way to take the lesser saphenous from a supine position. We'll actually position the patient just like we did for our greater saphenous. Because the lesser saphenous is a posterior structure in the leg, our setup here is not going to work just as it is. This is a great setup for the greater saphenous, but if you try to use this incision and then take your scope to go posteriorly and try to find that lesser saphenous, you're going to waste a lot of space, a lot of time trying to find that. So to make our lesser saphenous incision, I need to get that leg externally rotated a little bit more, and I need access to the back of the calf because that lesser saphenous lays right in between the heads of the gastrocnemius muscle. So I'll take the exact same bump we have here, and instead I will just push it superiorly underneath the thigh. Now, I don't like doing this for saphenous veins because I like the support underneath the calf to give me a little bit of tissue behind my incision. If I push this up too high, some of that tissue just kind of hangs in the balance, and it doesn't really help support you as you're dissecting or give you any resistance. But for the lesser, what this does is now I have access to the posterior side of the leg. So I could feel the popliteal fossa from here, and I can travel down just a little bit to in between the heads of the gastrocnemius muscle, and I can make my incision vertically right between the heads of the gastroc. So from this position, I can make my incision, I can cauterize down, find that lesser saphenous. If you can't find it right away, you can use your scope to do a tip search. The only awkward part about this is that to get onto the lesser saphenous, you have to reach your scope across the patient. Once you get into your tunnel, then you can line your scope up more with the lower leg and you can work your way down. If you find that you're running into the thigh, we can bump that leg up even higher, which seems a little crazy, but it provides excellent access. There you go. So what this does is this externally rotates even more. And from this angle, I can then have that scope along the posterior side of the leg without any difficulty.